Well, hello and welcome. I am Guy Stevens. I'm the founder and executive director of the Alliance Against Occlusion and Restraint. Thank you for joining us today. We've got another great program in store for you. I'll tell you a little bit about the Alliance if you're not familiar with who we are. The Alliance was started about 3 years ago. In fact, it was March of 2019 that we started. The idea behind the Alliance Against Occlusion and Restraint was we wanted to bring awareness and change around the issue of restraint seclusion being used in schools across the country. Our mission has continued to grow. We're really about changing hearts, minds, laws, policies, and practices so that restraint and seclusion are eliminated, not only in schools, but other settings in the country as well. We want to see safer schools for students, teachers, and staff. And we really want to do all we can to change the way so many kids are often treated in the name of behavior. We find that behavior is often the cause of a lot of negative and punitive things that are happening to kids, and we want to help bring about a change in the way that people are treated. So today we have another special guest joining us. So always very exciting to have the guests that we have, and we have Caroline Braun joining us today. Caroline's going to be talking about the use of restraint during feeding therapies. And I'll admit to you that this was not something I initially even knew was happening. So I think you're going to learn a lot here in our session today. As always, you're free to ask questions. We will be taking the questions at the end of the session today, but you're welcome to put them in the chat at any point because we can go back and kind of look and see who has asked questions. As you're probably aware, these sessions are always recorded. So they are available on Facebook, YouTube, and as an audio podcast after the fact. So we'll have those available so you can go back and share them or listen to them again if you'd like to. So with that, let me go ahead and get to our introduction. So I'm going to go ahead and introduce to you our special guest, Caroline Braun. And hello, Caroline. Caroline is an autistic speech language pathologist specializing in the treatment of complex motor, speech language, and feeding needs. She's the owner of a neurodiversity affirming private practice and a therapy advisor for the Therapist Neurodiversity Collective, an organization that I know that we're really big fans of that does amazing work. She's also passionate about raising awareness of traumatizing feeding practices and advocating for responsive approaches to feeding therapy. So this is certainly something that's very related to the work that we do here. And Caroline, when I was had the opportunity to connect with you and to learn a little bit about this, and I think I'd seen an article you had written before we had even connected, it opened my eyes to something I did not even really realize was a problem. And really excited to have you here today. Really excited to have you doing a presentation and sharing some of your experience with us. So welcome and thank you so much for joining us.
All right. Well, thank you so much.
Absolutely. So I'm going to go ahead and put your presentation up on the screen, and we're going to bring that up here so that everybody can see it. We're on your first slide here, and I'm going to let people in the audience know. I'm going to go away here, and I already see some our friend Amy Grant here providing some applause here. But I'm going to go ahead and go away and let you take over and run through your presentation, and I will join you again at the end. And we'll do some questions and have some discussion. So with that, let me hand over the reins and I will disappear, but I am only a voice away. If you need anything, just give me a call and poof, I'll appear.
Okay, thank you.
All right, thanks.
All right, so once again, my name is Caroline Braun, and like I said, I am a speech language pathologist or an SLP, and I specialize in serving children with more complex communication and feeding needs. Before I became an SLP, I was actually a behavior technician at an ABA or applied behavior analysis clinic. And that means I was trained in ABA methodology. And in fact, I was very committed to ABA interventions, and ABA informed my clinical practice as an SLP at the beginning of my career. However, as my career progressed and I began to see the negative psychological impact that my ABA-informed therapy was having on my clients, I began to pursue ethical alternatives. I became involved in advocacy to support neurodivergent affirming approaches to care after seeing the devastating effects that ABA, and particularly ABA-based feeding, was having on my clients who were attending local ABA clinics and ABA-informed feeding programs in hospitals here in the Baltimore, Maryland area, where I'm located. While I'm going to be providing some information about ethical care for children with feeding needs at the end of this presentation, most of what we'll be talking about today is not going to be about how I think we should be doing feeding therapy. And that's because we have a huge issue in feeding therapy that we need to address before we can even begin discussing what feeding therapy should look like. And the problem here is that an influential model of feeding therapy, which is ABA-informed feeding therapy, is dehumanizing, potentially traumatic, potentially dangerous, and is falsely touted as the gold standard, despite being supported by fundamentally flawed research. This ABA-informed method of feeding intervention is one that few of my professional peers and even fewer parents are aware of. In fact, many parents I've met through my clinical work and my advocacy efforts have reported that they had no idea what their children would be subjected to until ABA feeding therapy had already begun. Today, we're going to be talking about the ways in which these behavioral feeding therapies dehumanize children and adults, because they can also be applied to adults. And they do this by forcing compliance through the use of rewards, mechanical restraint, and physical restraint. And it's my hope that by raising awareness of these practices, we can more effectively resist them and advocate for respectful and ethical care. Okay, so before we talk about particular feeding therapies specifically, we need to define what we're actually seeking to treat when a child is referred to feeding therapy. Many of our kids are now qualifying for a diagnosis of pediatric feeding disorder, or PFD for short. And a PFD is defined in the literature and in many professionals' clinical practice as impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. Now, the language that's characterizing feeding disorders is clearly based in an inherently ableist and medical model of disability that not only stigmatizes disabled people, but in my clinical experience, misidentifies aspects of neurodivergent feeding as disordered rather than merely different. For instance, I often see that autistic children who are highly selective in their eating automatically are qualifying for feeding disorder diagnoses because their limited diet is not considered age appropriate. However, it's my clinical opinion that if these children are able to access adequate calories and most of the nutrients from foods they are accepting, or those nutrients can be easily supplemented, they're not experiencing distress during eating, and it doesn't appear that their selective eating is hindering their ability to access their environment, like go to restaurants or birthday parties if they want to, then I don't feel that this is a disorder. We can certainly provide parent coaching to teach strategies for continuing to introduce new foods in a safe way, but thinking of these differences as disorders can get us into trouble and lead to kids being in therapy, sometimes these really, really damaging therapies, for years and years with minimal to no progress. Children with feeding difficulties often do benefit from professional support, but pathologizing eating differences that result from different neurology and sensory systems just isn't helpful. And it causes parents undue anxiety and can lead to stressful meal times. It can also cause children to become self-conscious and anxious about their eating. And this is a very nuanced discussion that I and other professionals are currently working through and providing more information about. But the key thing that I want you to know here is that for the purposes of this presentation, there are 4 areas that children may demonstrate feeding differences or challenges in. All right, so children may demonstrate difficulties in one, several, or all domains of feeding. And once again, those domains are shown here. We have psychosocial, medical, nutritional, or feeding skill. And medical concerns refer to things like acid reflux, abnormal gastrointestinal motility, irritable bowel syndrome, Crohn's disease, a number of different medical conditions. Nutritional concerns can be something like a nutritional deficiency or food intolerances, while difficulty with feeding skills can include difficulty with swallowing, chewing, cup drinking, sensory processing, and more. And those psychosocial challenges refer to challenges that can include feeding aversions, challenging mealtime behaviors, and these things that we see that can often lead to highly selective eating. So feeding challenges and disorders are actually remarkably common among neurotypical children, and prevalence increases among disabled children and adults. 20 to 50% of typically developing children actually have trouble eating. 53% of children with cerebral palsy have difficulty feeding or swallowing, and in some studies, estimates are much, much higher. About half of infants with Down syndrome struggle with feeding, and statistics vary widely for autistic individuals, as you can see here. Among autistic children, feeding difficulties and differences are so common that it was once a diagnostic criterion for an autism diagnosis. So we're talking about a large number of kids that are affected by feeding differences, feeding challenges, and feeding disorders. So as more and more neurodivergent people, particularly autistic children, are subjected to ABA services, more and more ABA professionals are claiming feeding within their scope of practice. Children are already at ABA centers for 15, 20, even 40 hours of therapy a week. So adding feeding services is an easy way for these clinics to make snacks and meals billable for insurance so centers can bring in more money. ABA professionals and ABA providers informed by this methodology view feeding and eating as a behavior that can be changed through the use of operant conditioning. Operant conditioning refers to the use of rewards and punishments to shape a target behavior. For instance, in the world of animal experimentation, an animal may receive a reward of food for completing a task correctly, or a painful shock for doing the task incorrectly. Notably, the BACB, the Behavior Analysis Certification Board, continues to condone the use of punishment for humans, including children. Some of the most egregious forms of punishment we see ABA professionals using today is at the Judge Rottenberg Center, which has a history of using life-threatening force during physical restraints and continues to use devices to administer painful shocks to disabled children. So coming back to feeding, it's really problematic to view eating as a series of behaviors that can be shaped through operant conditioning, or that concept of applying punishments and rewards. Eating is a highly complex motor and physiological process, and it's actually the only childhood activity that requires all sensory systems like taste, hearing, sight, touch, balance, and more to be engaged all at once. ABA professionals try to shape the following highly complex feeding challenges through the use of applying punishments and rewards. They try to address chewing, swallowing, gagging, vomiting, aspiration, which is material entering the lungs, as well as disordered suck, swallow, breathe patterns. And this is the eating pattern that infants who are breast or bottle fed use to feed. And this is a huge problem because ABA professionals are woefully underqualified to address feeding concerns. RBTs, or registered behavioral technicians, often provide the bulk of behavioral feeding interventions, but they only need a high school diploma and receive only 40 hours of broad training, frequently delivered online with inconsistent supervision to qualify for their credential. And it should be noted that people can work in these clinics as behavioral technicians without even these qualifications. For instance, when I was a behavioral technician, I never underwent the 40-hour training course. And I continue to see clients and bill insurance anyway. BCBAs, or board certified behavior analysts, are the master's level clinicians in ABA, and they receive graduate coursework in applied behavior analysis. As part of their standard training, neither RBTs nor BCBAs receive instruction in typical feeding development or training in how to assess, treat, or identify the structural or physiological factors that often cause children to develop feeding disorders. In contrast, this information is embedded within master's level coursework for all speech-language pathologists and some occupational therapists. SLPs and many OTs receive extensive graduate education in anatomy, physiology, swallowing, and respiration. It's especially concerning that BCBAs are claiming competency to work with increasingly vulnerable populations like NICU babies, neonatal intensive care unit babies, who are having feeding and swallowing challenges. More and more BCBAs are becoming certified lactation consultants, which requires only a 52-hour course in continuing education. If you're unfamiliar, a lactation consultant is someone who assists in breastfeeding and in infant feeding challenges. And for context, even though I'm a feeding specialist and an SLP, I don't treat infant feeding. And this is despite the fact that I've received extensive graduate education in anatomy and physiology of feeding and swallowing, hundreds of hours of supervised field work working with children and adults with feeding and swallowing needs. I can provide modified barium swallow studies, which is essentially interpreting an X-ray of the swallow. Since graduation, I've taken hundreds of hours of continuing education in the area of feeding, And I've truly lost count of the number of adults and children I've worked with feeding and swallowing issues. Despite all of this experience and education, I still don't claim competency to treat infants because it's not an area that I've received adequate education and supervision in doing. Yet BCBAs in my area here in Maryland are treating these vulnerable infants with only a 52-hour certification course. And despite the remarkable lack of training, RBTs and BCBAs are often the primary professionals providing feeding therapy at ABA clinics and even internationally renowned hospital programs throughout the United States. So let's take a look and talk about the components of an ABA-based feeding program. Most ABA-based feeding programs combine the use of rewards and techniques that are known as escape extinction procedures. The use of rewards and escape extinction are often combined to induce compliance during meal times. Much of this presentation will focus on the use of escape extinction, which we'll define and discuss in detail in a little bit. However, I just want to add some information about the problematic nature of using rewards to induce compliance in feeding, since most, if not all, ABA-based feeding programs will include this. Notably, many SLP-led and even some OT-led feeding programs will also use rewards to coerce kids into doing things they don't feel comfortable with as well. So as I mentioned, virtually all ABA-based feeding programs are going to use rewards, and they're going to identify those rewards so they can induce the child's compliance in reaching feeding goals like interacting with or consuming non-preferred foods or eating a particular amount of food. Rewards can include things like preferred toys, access to preferred activities, access to a preferred food if they eat a non-preferred food first, and also access to caregivers or affection. And this is one that I find particularly disturbing. In my personal clinical experience, I used to have a client who attended a local ABA clinic that actually advertises their feeding program quite aggressively in my area here in Maryland. My client refused to eat most novel foods and even some of his familiar preferred foods during their treatment. In an effort to get him to follow their commands, his ABA therapist told him that he could see his mom if he took a bite of food, but he couldn't see her if he didn't. Well, this child, like many children, loves his mom, and he wanted to see her, so he finally took a bite. But it turns out she wasn't even there in the clinic yet. Since dangling the promise of seeing his mother, the single most important in this child's life, was successful in manipulating this child into doing what they wanted him to do, that ABA team then discussed the possibility of adding access to his mother as a reinforcer during feeding therapy. And that was really awful for me as a relationship-driven and trauma-informed provider. I can't imagine what it was like for that child. So what's wrong with rewards and feeding? Well, rewards are highly problematic because they facilitate the development of external rather than internal motivation for eating. Rather than discovering that eating can be pleasurable, tasty, or satisfy hunger, children who are rewarded to eat are explicitly taught not to honor these cues. Instead, they learn to eat for the external reward of getting something they want or receiving an adult's approval. Many programs require children to eat non-preferred food and then reward them by allowing them to eat a food they enjoy. If they don't eat the non-preferred food, then they can't have the food they like. This practice is especially problematic because it sets up this hierarchy among foods, and it communicates to the child that that non-preferred food must be so disgusting that they have to be induced to eat it with a reward. That virtually almost guarantees that the child will never come to see that food as enjoyable in its own right. And this doesn't even begin to scratch the surface of the ways in which these types of hierarchies among foods can impact disordered eating and body image concerns later down the road. And we already know that rates of anorexia are elevated among autistic women and girls, who often find themselves subjected to ABA feeding programs first before they get more appropriate treatment. Additionally, rewarding children for eating can damage the relationship between parent and child in devastating ways. Typically, ABA-based feeding programs implement rewards using a procedure that's known as differential reinforcement of incompatible behavior. And really, this is just a fancy way of saying that you reward the child when they are doing something that they simply cannot do while also engaging in what you've identified as the problem behavior. So in the case of the child who refuses to open their mouth to accept the spoon during meal times, the child is only rewarded when their mouth is open, and they are ignored when their mouth is not open. Providers often encourage parents to withhold preferred items, activities, and even affection unless the child is performing the desired behavior. As you can imagine, that can be highly disruptive to the bond between parent and child. And it's also inherently dehumanizing because it makes a procedure out of ignoring children's attempts at autonomy and honoring their internal cues. We have to come from a place that our kids have valid reasons for demonstrating challenging mealtime behaviors rather than identifying their behavior itself as problematic and seeking to induce compliance with a system of planned ignoring, rewards, and worse. So now we're going to talk about escape extinction. And escape extinction procedures are those in which an adult does not let a child's behavior result in escape or avoidance of a task. Within feeding therapy, escape extinction procedures prevent children from using their behavior, like running from the table, throwing food, even saying no, to escape or avoid eating. And this is really, really unfortunate because so many of these behaviors kids are demonstrating during mealtimes are communicative in nature and are either forms of self-advocacy or attempts at claiming bodily autonomy. Escape extinction procedures, regardless of what they are targeting for extinction, often seek to extinguish the self-advocacy attempts of children with significant communication needs. What's even more unfortunate is that the ABA literature considers escape extinction to be a vital part of a successful behavioral feeding program, even going so far as to say that escape extinction is the most important and most research-proven technique for decreasing food refusal and increasing consumption of new foods. The next slide and the following slides come with a trigger warning for ABA-induced trauma as well as restraint. We're going to be talking about some really awful things that may be triggering for anybody who has experienced a violation of their bodily autonomy through restraint or coercion. I just want you to know that so you're not caught off guard unexpectedly. So I'll give you a minute to decide if you'd like to continue. Okay, so now we're going to talk about escape extinction procedures in ABA-based feeding. So one type of escape extinction is the representation of food the child has spit out, or in some cases even vomited. The idea is that the child is spitting or vomiting to escape the task of eating, so the adults are representing what they've spit out repeatedly until the child eats the represented material. And this way, the idea is that the child learns that they can't use that behavior to escape eating. Representing expelled food is more common now than representing vomit, but colleagues have reported that this still occurs in some clinics. And I really hope I don't have to tell you that representing food a person spits out or vomits is inherently disrespectful and dehumanizing. Doing this completely violates the child's right to bodily autonomy, undermines their body's physiological cues, and communicates that they will comply at any cost, regardless of how uncomfortable, even painful it makes you. And in my experience, representing what the child spits out results in one of two responses. We either one, have a child who gives up and complies, thereby masking their discomfort and ignoring their body's needs to please an adult, and often an adult that they really care about. Or we have a child who fiercely demands their right to bodily autonomy, and in the name of self-preservation becomes more adamant in their refusals. These children may protest, scream, run away, or even become physically aggressive in an effort to demand their basic human right to bodily autonomy. Many of these children, in my experience, appear to have what's known as a pathological or pervasive demand avoidance, also known as a PDA profile. Kids with these profiles have a strong need for control and autonomy, which is often paired with anxiety. This is something that these ABA-based feeding programs not only fail to accommodate, but actually exacerbate and make even worse. In some cases, children who continue to advocate for their right to bodily autonomy and refuse to comply with feeding demands are then subjected to more aversive procedures like the ones we're going to talk about next. However, it's clear from both the literature and my clinical practice that less invasive procedures and interventions are often discontinued quickly or even skipped altogether in favor of the most restrictive and aversive procedures possible. One of these procedures is known as non-removal of the spoon, and that's what you see here on this slide. In this procedure, the adult, known as a feeder, places the spoon roughly an inch away from the child's face and tells them to take a bite. They then don't remove the spoon until the child opens their mouth and the spoon can be inserted into the child's mouth. Now, the spoons used in this procedure are often rubber-coated to prevent injury, since some procedures allow the feeder to put the spoon in between the child's closed lips and turn the spoon to pry the lips and mouth open. Now, some providers only put the spoon in the child's mouth when they open it willingly to accept the bite, but many quickly insert the spoon into the mouth whenever the child's mouth is open, as they scream, cry, and protest. Some of the leading researchers in ABA-based feeding have advocated for that latter approach in their research, going so far as to even insert the spoon when children are actively opening their mouth to breathe. Forcing food into the mouth of an unwilling child is dangerous, since the body is not prepared for food. As a result, non-removal of the spoon techniques carry a risk of aspiration, which is that entry of material into the lungs. And it also carries a risk of choking. This is one reason why many behavior-based programs will use purees in the initial stages of feeding therapy, even though the child may be able to manage more complex textures like crunchy foods or meat and vegetable textures, which are much more motorically complex. And the fact of the matter is, it's just easier to force puree into the mouth of an unwilling and terrified child, and there's less risk that they'll choke in the process. And I want to take a moment to mention that this procedure, this non-removal of the spoon procedure, is ubiquitous within an ABA approach to feeding. Virtually any ABA-based feeding program, whether it's in a school setting, an ABA clinic, or a hospital-based program, is going to use this as one of their treatment interventions. Unfortunately, SLPs and OTs who are trained in behavioral feeding interventions will often use these as well. Since this procedure is so aversive to children and adults who are subjected to it, mechanical restraint is often added to prevent them from successfully escaping the session. And mechanical restraint refers to the use of equipment or devices like straps on feeding chairs to restrain children and prevent them from moving or escaping. Chairs like the ones I've pictured here, which is produced by a company called Kikaroo, can either be used as a supportive device or a restraint, depending on how it's used in feeding therapy. I've used this chair quite frequently in clinic-based therapy, and several of the clients I've worked with have actually had families purchase them for home use as well. But the key difference here is the way we use these chairs is much, much different than the way they're often used in ABA-based feeding practices. And the literature regarding escape extinction in ABA often neglects to reveal the fact that mechanical restraint is often being used, whether intentionally or not, as a form of escape extinction. Oftentimes, procedures like non-removal of the spoon or representing food that the child has spit out take place in these chairs when the child is restrained. These chairs frequently feature straps and trays that make it difficult for the child to leave the chair. So if you see there, that tray, typically children are not able to remove it on their own, especially if there's any kind of coordination or motoric difficulties. There's also straps that can be used to secure the child in place, and many children are not able to escape those straps on their own without assistance. And the thing is, placing a child in a chair that they can't escape and denying their pleas to leave is not only escape extinction and highly aversive, but it is a form of restraint, and we need to recognize it as such. And notably, a mechanical restraint that serves as a postural support aid for one child can become a mechanical restraint for another. The difference truly lies in the purpose of the device and whether or not the provider has the child's consent to use it. Many children with feeding needs require the use of adaptive seating or other devices to achieve upright positioning for safer and less effortful eating. And these devices are used always with the child's consent and with their comfort in mind. Aids to provide postural support are therapeutic. Tactile and physical supports we can provide to children with their consent are therapeutic. But devices intended to restrain a child to force compliance are never therapeutic, and physical restraint is never therapeutic. When procedures like non-removal of the spoon do not coerce children into eating, more forceful measures can be taken in the form of a procedure called physical guidance. I'd like to take this opportunity to issue another trigger warning for the following 2 slides, because one will list the steps in the procedure, the physical guidance procedure, and the second will actually feature an image of a physical guidance procedure, which does involve physical restraint. While I wish I could have kept this presentation free of triggering content and images, this is just not the reality of the situation when it comes to pediatric feeding therapies. I'm going to show you this because most professionals and parents are completely unaware that this is something that can and does happen in feeding therapy. And it's an invasive procedure that, based on the research and my clinical experience, is disproportionately used with our most vulnerable kids who are often neurodivergent and have communication needs. So when applying the physical guidance procedure, the adult feeding the child escalates that non-removal of the spoon procedure by using their other hand to apply pressure to the jaw to open the child's mouth so they'll accept the spoon. Notably, though, there's inconsistency in the literature regarding what even constitutes a physical guidance procedure. The details of this procedure are actually so inconsistent that a team of researchers looking through the ABA literature recently sought to examine what defines a physical guidance procedure, and they found that it refers to 4 to 6 different techniques. This means that there isn't a true standard of care when it comes to implementing this highly aversive procedure. One of the most common forms of physical guidance I've found that my clients have been subjected to is going to be shown on the following slide. And in this variation, the feeder is positioned in front of the child and performs non-removal of the spoon. The feeder then uses their fingers to apply pressure to the child's face to elicit that jaw opening, and mechanical and physical restraint are often used. And what's important to note here is that you're not going to find an image of this procedure online or in the literature. And the one video I found in which a child is subjected to this procedure and publicly available is deeply buried in YouTube's algorithm, and it's really difficult to access. If you feel you need to see this procedure in action, I did write an article about ABA-based feeding for the Therapist Neurodiversity Collective, and you can access the video there. Just know before watching that it is really difficult to watch. And because none of those pictures exist, we had to make one ourselves. And the image that you see here is based on descriptions in the literature, what I've read in my clients' reports from their BCBAs, and what I've seen from parents' video recordings of ABA-based feeding sessions. This is also consistent with what my own clients have reported in their firsthand accounts of what they've experienced in ABA feeding therapy. It's rare that parents are even permitted to film or photograph these procedures, by the way. They often have to sign agreements that they won't photograph or record what's happening, and they're typically strongly discouraged from viewing the session. Most are not allowed in the room during this therapy, and the ABA literature even notes that it's very difficult for parents to watch and see these procedures being implemented on their children. So this picture here is a form of physical guidance. In this procedure, you have an adult in front performing non-removal of the spoon and escalating the procedure into physical guidance by taking his hand and applying fingers to the temporomandibular joint here that you apply pressure to in an effort to elicit jaw opening. As you can see in this image, the child is mechanically restrained, which means that equipment is being used to restrain his movement. And this is really typical in ABA-based feeding, since the kids really want to escape this highly aversive interaction, but the therapist's goal is to diminish that escape response, to actually extinguish it, to prevent them from trying to leave. For smaller children, typically only one adult uses physical force, usually standing behind the child, to keep the child's hands down, to keep them from swatting the spoon or hitting the feeder. However, several former clients and families I've met through advocacy have reported that their older or stronger children were restrained by as many as 4 adults at once, one on each arm, one to restrain the legs, and another in front to force the jaw open and put the spoon inside. The reason that this procedure is called physical guidance is, once again, because there is that accessing the jaw through the hands, but it's not considered part of the standard physical guidance procedure to have an adult restraining the child. That's something that's really left out of the literature. And as you can imagine, the reality of this procedure is far less tidy than the image that I'm showing you here. I've encountered kids who other therapists and their parents report would do absolutely anything to escape: twist their head, kick, bite, scream, hit, scratch, destroy equipment, and try to hide in the clinic space. One parent recently reported that when this procedure was done to her son, he screamed at the therapist restraining him, "Why are you treating me like an animal?" So restraint, whether mechanical or physical, is traumatic and dehumanizing. It's also found throughout the ABA feeding literature, though it's often not accurately reported in published studies. In a recent review of the literature, over half of study designs in selected ABA feeding studies used restraint or other restrictive procedures. At least 30% of study designs using restrictive procedures clearly reported the use of restraint, but many studies failed to provide adequate details of their study protocols, meaning that as many as 55%, so over half of designs evaluated, may have relied upon the use of mechanical or physical restraint or both. We just don't know how prevalent restraint is in the literature because researchers don't clearly specify their procedures. And this is a huge problem. If the success of a procedure relies upon incorporating restraint, then it is inherently disrespectful, damaging, and dehumanizing. If a researcher feels the need to hide or obscure their use of restraint on children, that is not only misleading, it's unethical. So at this point, you may be asking, why are these methods even being used to treat children with feeding needs? And well, supporters of these interventions often argue that A, these interventions are only reserved for the most severe cases of food refusal and selectivity, and B, that these are the only evidence-based methods that can be applied when all other less invasive methods fail. However, both of these arguments are just inaccurate. And my clinical experience, the experiences of my families, and the poor quality of the ABA literature itself shows that these claims are just not true. Many of the children subjected to these methods in research and in my own clinical practice do not have life-threatening feeding challenges. In my clinical experience, many have not even been provided access to less invasive methods of feeding therapy before highly aversive behavioral methods were introduced. For instance, I've worked with autistic children who ate significantly limited diets. So that means they may eat maybe 3 or 4 purees that are often baby foods. Many of them have trouble progressing from baby foods to different kinds of puree. And they may be drinking 1 or 2 different kinds of drinks. In quite a few cases, these children were actually getting adequate calories, growing as expected, and even getting more nutrients and things like fiber in their diets than other children their age, and even quite a few adults who are eating the standard American diet. Yet professionals and society perceive their eating as weird. And as a result, these kids end up in traumatic force-feeding programs. Yes, these kids are highly selective in their eating, and they don't accept new foods readily. And yes, there are certainly things that we can do to support feeding at home, but restraining kids and violating their bodily autonomy is never the answer. I've conducted extensive research and literature reviews on ABA-based feeding that I hope to turn into publishable work in the future. But for now, if you're interested in learning more about these articles I've referenced in this presentation, you can find that information with citations, access information, and descriptions of the salient research on my website, and I'll post it after this presentation later on this week. And I feel that examining the quality of the evidence is vital to feeding therapy, as many ABA providers are fraudulently claiming that ABA-based feeding is the only evidence-based treatment for pediatric feeding disorders. Some even go so far as to say it's the gold standard. And this just, quite frankly, is a gross misrepresentation of the data we have available. I'm also interested in examining the research base because in my experience, parents' ethical concerns have been dismissed by providers who claim that their treatments are evidence-based practice. So many providers now are really weaponizing the term evidence-based practice. And quite frankly, I'm really haunted by what happened to a young autistic client I worked with about a year ago. He was attending a day program at a large ABA center owned by a big ABA company in my area. And that day, his mom told me how he had been restrained and force-fed and feeding therapy by his ABA techs that day. I voiced my concerns to her and also to the BCBA he was working with. His mom said that she was also concerned about how restraint may affect her child, but she said she trusted her ABA team. She said that everything they do is evidence-based. In fact, they told her that ABA is the gold standard for treating absolutely anything related to autism. She was concerned, and rightly so, but the providers repeatedly dismissed her concerns by referring to their supposedly large body of high-quality evidence. So I want to take an opportunity to talk about that evidence. And by doing so, I hope you'll get the information you need to make the best and most respectful choices for your loved ones. So what does the evidence actually tell us about treatment for children with feeding needs? Well, the leading research, education, and advocacy organization for pediatric feeding disorders, called Feeding Matters, clearly states that there is no longitudinal evidence-based best practices for intervention. This is due to the lack of longitudinal information available in the current research and the heterogeneous nature of the population of children with feeding disorders. In other words, this means that no therapy, whether it's ABA, speech, OT, dietetics, or any one particular name brand feeding program, is considered best practice for treating kids with feeding needs. We have a lot of work to do in this area. And I do also want to add a quick note about Feeding Matters since I've highlighted them here. I highly recommend that any families who choose to visit this site do so with caution. I have found several ABA clinics and hospitals here in the Maryland area that are advertising on the site and who use the dehumanizing methods we've discussed earlier in this presentation. Some of the listings of these ABA centers were so problematic that some were recently reported to Feeding Matters for spreading misinformation, namely that ABA is the only evidence-based treatment for feeding disorders. Meanwhile, other clinics listed on the site state that they have ABA, BCBAs who are qualified to treat dangerous swallowing disorders, which, as we discussed previously, they are not qualified to do. Unfortunately, these clinics are still allowed to advertise on the Feeding Matters provider directory site with only minor revisions to their ads. Additionally, some of the key members of the Feeding Matters team are affiliated with highly aversive and behavior-based programs, such as the Marcus Autism Center in Atlanta. As a result, I don't affiliate with or refer families to this organization, which is a huge shame because so much of their information, research, and advocacy has been so vital to raising awareness of feeding challenges and getting families access to treatment. But unfortunately, the risk of harm is too great for me to refer families there without this warning right now. So when it comes to quality concerns regarding provision of ABA services, one of the biggest problems, both in practice and the literature, is failure to follow best practice guidelines. Best practice guidelines indicate that treatment of feeding disorders should take place within the context of a multidisciplinary care team. And at the very least, a thorough assessment of all 4 domains of feeding, which we talked about earlier, medical, nutritional, feeding skill, and psychosocial should take place prior to initiating feeding intervention. Unfortunately, current studies reveal that researchers who study behavioral-based feeding interventions often fail to adopt a team-based approach to assessment and treatment, and as a result, interpret participants' feeding disorders through the isolated lens of the psychosocial or behavioral domain. In a review of the literature, researchers found that many published studies were violating best practice guidelines. They found that prior to starting behavioral feeding therapy, only 62% of studies reported that a medical assessment was completed. Only 24% noted that an oral motor assessment was completed. And only 10% identified that nutritional assessment was completed. And remember, these studies took place under more rigorous conditions than many community programs, since they were conducted by researchers actively seeking to control for a variety of variables that could influence their study. We currently have no data on how well feeding clinics housed in ABA centers in the community are abiding by best practice guidelines. And in my clinical experience, I've worked with children, some of whom have been subjected to physical restraint and force feeding at major ABA clinics in my state, and who then have the audacity to advertise trauma-informed CEUs to other ABA professionals, but that's another issue entirely. And they provide this treatment, this ABA-based feeding treatment, without appropriate medical clearance, oral motor assessment, or collaboration with any other professionals related to nutrition or other therapy disciplines. These children who eventually end up in my care present to me with extensive dental decay, significantly delayed oral motor skills, and/or significant gastrointestinal concerns like impaction that puts them in the hospital. However, ABA providers continued to forcibly feed these children despite serious medical concerns. And unsurprisingly, those interventions failed. And when ABA-informed providers fail to consult with other professionals, children's difficulty with eating can be dismissed as bad or manipulative behaviors to be extinguished when there's actually something seriously wrong. Mischaracterizing and dismissing children's challenging mealtime behaviors as manipulation reveals a fundamental and dangerous lack of knowledge regarding the anatomy, physiology, and development of feeding, and it sets up an adversarial relationship between adults and children. Another problem with the evidence supporting escape extinction methods in feeding is that the best studies purportedly supporting the use of these procedures in pediatric feeding really aren't focusing on escape extinction itself. In fact, many of the children in the highest quality studies, which are typically conducted in hospitals, are often receiving a variety of interventions besides ABA-based feeding therapy. These other interventions include things like oral motor intervention from SLPs, sensory processing intervention, and activities of daily living support from OTs, medical management from doctors, or nutritional intervention from dietitians. In this kind of environment, this kind of multidisciplinary environment, it's difficult to isolate that ABA, and particularly escape extinction procedures themselves, are the factors that resulted in improved feeding. You'll also notice here that I put the word success in quotation marks. And I do that because the things my clients, their families, and I often consider success in feeding can be quite a bit different from what other providers define as success. And we'll talk about that more in a bit. Additionally, the details of the individual escape extinction procedures used in these studies often varied from study to study. In the case of non-removal of the spoon, for example, some studies specified that the child had to consent before the spoon was placed in the mouth, while others allowed feeders to put the spoon into the mouth anytime the child's mouth was open, even if that meant their mouth was open because they were actively screaming no. Regarding physical guidance, some procedures allow the feeder to apply force to the jaw to open it, while others specify that the feeder must identify that the child is relaxing their jaw, so no force is applied. Other procedures involve the feeder putting their fingers in the child's mouth to elicit opening of the jaw. And this brings us to our next concern. When it comes to research, it's really important that studies are replicable. This means that anyone who conducts the same experiment will get similar results. But many of the studies supporting the use of aversive feeding practices don't include adequate information to replicate. The highest quality studies included in the reviews that I've done on ABA-based feeding are what's known as meta-analyses. And a meta-analysis really is a study that's assessing the existing studies to these existing studies that are relevant to a research question. And they're doing that to make conclusions about the intervention being studied. The problem, though, is that a meta-analysis is really only as good as the quality of the studies it's reviewing. And that's a significant problem because the studies included in meta-analyses that support escape extinction procedures often aren't really designed in such a way that they can provide evidence that escape extinction procedures are the reason for increased food acceptance or reduced challenging behaviors. Most studies fail to adequately describe the procedures they used, which means that their studies can't be replicated. In these studies, it's often unclear what types of escape extinction procedures were used, how often they were used, and how many children they are used with. Additionally, the escape extinction procedures themselves are so poorly described that we often don't really know how they're being implemented. For instance, it's really uncommon for these studies, even the ones that are rather descriptive in their protocol section, to explain where adults are positioned and how adults are interacting with the child physically. So whether they're applying any kind of physical restraint or not. Another problem is that we just don't have the long-term data to support the use of these dehumanizing methods. Not that we'd even want it if it existed, in my opinion. Reporting of longitudinal outcomes is highly inconsistent within and often absent from feeding literature across disciplines. So this part isn't just an ABA problem. It's a problem no matter what approach you're coming at the literature from. And in one of the highest quality studies I found, it's a review of 11 multidisciplinary feeding studies by Sharp et al. In 2017. They reported that participants typically maintained progress made in treatment following discharge. However, only two of the 11 studies reviewed did not include any measure of progress maintenance post-discharge. Another included only a parent satisfaction questionnaire. Of the 9 studies that included post-treatment measures, the time of post-treatment follow-up varied between 1 and 24 months. Reporting of outcomes was complicated by the fact that you often lose track of participants during longitudinal studies like this. And while that's expected and less of a concern when your study has a larger number of participants, much of the ABA literature, whether it's feeding related or not, often contain very few participants. And when you have only, say, 5 participants and lose half of them, it's really difficult to make conclusions regarding the longitudinal effects of your intervention. These very small studies are often called single case study designs. And regarding single case study designs, children with feeding needs are remarkably heterogeneous. And this is a problem when we're looking at such small case designs. The fact that these children are so heterogeneous means that they're very different from one another. And what works for 2 children in one study really can't be extrapolated to make the argument that it will work for other children, especially if those children have different feeding needs. This is one of the key problems with relying heavily on single case study designs to inform our treatment methods. Additionally, these studies often take place in highly structured clinical environments, so it's unclear the degree to which progress generalizes to more natural environments, especially considering that studies are so inconsistent in their collection and measurement of long-term outcomes following treatment. Also, researchers often select children from their own clinics and have a vested financial interest, which is rarely disclosed, which could result in a higher risk of bias in the study and could theoretically cause the researchers to overstate the effectiveness of their methods. This is something that I hope to investigate in my research in the future. Single case study designs certainly do have their place in research. For instance, there are some conditions that are so rare that a larger study just is not possible because there would be too few participants. Additionally, single case studies can allow us to get information more quickly on possible results of an intervention because they typically take less time to complete. When combined, A large number of single case studies can be reviewed and the results analyzed to make more significant conclusions regarding the efficacy of a treatment procedure. However, there are so few single case study designs, particularly those designed by ABA feeding professionals, that adequately report the potential negative effects of their intervention. So even if a large review of single case studies were to be presented, we're really not getting the whole picture. And that's largely because these studies aren't designed to measure the possible negative effects of the intervention, like disrupted attachment to caregivers, psychological distress, or trauma. But when it comes to feeding, it's really important to note that while data certainly is important, there are so many aspects of successful feeding that just can't be quantified. We can't plot a child's perception of their felt safety on a graph. We can't quantify their attachment to their caregiver, their perception of their own success, their feelings of self-confidence, their anxiety, or their increased self-esteem. So much of successful feeding therapy is assessed in a qualitative way rather than quantitative. This means that I'm looking at the things you can't really put a number on to measure with a list of checks or minuses. My clients don't always have access to mouth words or alternative or augmentative communication yet, so that they can use language to tell me how they are feeling or how feeding therapy is impacting them. And as a result, I must rely on their reactions and the nonverbal communication, which I have to describe qualitatively rather than quantitatively. And it's so easy to measure the number of bites or calories a child consumes, but it's harder, if not impossible, to measure a child's joy, their distress, the quality of the feeding relationship between child and parent, or the child's perception of their own abilities. And these aspects of feeding are just as important and often neglected in behavioral approaches to feeding. But fortunately, there is an ethical alternative to highly aversive and dehumanizing feeding interventions. A growing body of research supports the use of responsive feeding therapies starting in infancy, or responsive feeding techniques starting in infancy, to foster the development of healthy eating. The information in this slide, as well as many of the following slides, are from the Responsive Feeding White Paper, which was written by a group of interdisciplinary feeding professionals who are really leading the way in providing responsive feeding therapy. They define responsive feeding therapy as therapy that facilitates the rediscovery of internal cues, curiosity, and motivation while building skills and confidence. It is flexible, it prioritizes the feeding relationship, and it respects and develops autonomy. While ABA-informed providers often seek to control how much a child consumes and may even physically force the child to eat, responsive feeding professionals prioritize sharing control with the child to develop a trusting and respectful feeding relationship. Responsive parents and professionals recognize that children have the basic human right to determine if they will eat the food presented and how much of that food they will consume. And here we have the values of responsive feeding as defined by Rowell et al. In that responsive feeding white paper that I mentioned. And I really recommend that anybody who's interested in feeding therapy type that into their search engine, responsive feeding therapy white paper, and you will have free and easy access to this paper. And the values of responsive feeding therapy include individualized care, intrinsic motivation, autonomy, competence, and relationship. I'll discuss all of these a bit, but there's a few that we'll focus on in particular since it's especially relevant to this discussion regarding what is and is not responsive and respectful in terms of feeding therapy. Responsive feeding therapy is always going to be individualized to the needs of the child and the individual family. Sometimes a critical part of providing responsive care is ensuring that our feeding team is made up of several different and highly skilled professionals who can address different domains of feeding that we discussed earlier. This is consistent with the best practice guidelines to provide feeding therapy within the context of interdisciplinary teams. Responsive feeding also prioritizes the development of intrinsic or internal motivation rather than external or extrinsic motivation. External motivation in the form of rewards, pressure, praise, or punishment interfere with the development of that internal motivation for eating, and may actually reduce motivation for eating. For instance, we know that stress inhibits our appetites and diminishes our desire to eat. We prioritize intrinsic motivation because responsive providers operate from the perspective of presuming competence. We presume that the majority of our kids are able to develop and learn to interpret physiological cues related to hunger. When the motivation for eating is internal, there's no need for those external cues. And I cannot overstate enough how vital autonomy is to responsive feeding practice. But I think it's important we take a moment to distinguish between independence and autonomy. An individual is independent when they don't need assistance to accomplish a task. In contrast, autonomy refers to an individual's ability to make their own decisions and pursue their own goals and interests, even if they need assistance from others to reach their goals. Most of our kids are not going to be independent with eating. They are kids after all. For our disabled kids, they may need even more assistance. However, a child's inability to eat independently should not impact their autonomy. A child may be completely dependent upon an adult to eat. However, responsive professionals and parents can honor autonomy while providing as much or as little assistance as needed while honoring the child's cues. And for instance, think about infants or babies in your life. A 6-month-old is obviously not independent during feeding. They require a caregiver to provide for them. But baby can demonstrate their autonomy, which is their desire to eat or not to eat, in a variety of ways. If the baby leans forward towards the spoon with an open mouth, they're indicating, yes, I do want to eat. But if baby leans back and away from the spoon, turns their head, or even swats at that spoon, they're indicating their desire not to eat that food right now. And if we put the spoon in the baby's mouth, even when they're indicating that they don't want it, we're violating their autonomy by disregarding their desire not to eat. If we honor their refusal, we honor their autonomy and demonstrate that we are responsive in interpreting their mealtime cues. So in short, we undermine autonomy when we use pressure, restraints, force, punishment, coercion, or rewards. But we support autonomy when we accept the child's right to say no. We honor bodily autonomy and integrity. We do not extinguish signs of distress, and we respond to all forms of communication as valid. So in speaking of competence, it's my experience that part of teaching parents to support children's autonomy requires me to support parents in developing their own sense of competence. Both parents and children can and must learn to see themselves as competent during meal times. As a professional, I can support parents' feelings of competence by providing targeted coaching, education, and support. As adults, we can support children's competence by recognizing that progress is more than just the number of bites or the number of different types of foods they consume. At the end of the day, though, responsive feeding is dependent upon the development of a healthy and happy relationship between the adult and the child. Healthy attachment and trusting relationships should never be sacrificed for short-term goals like counting bites or calories. And this is exactly what ABA-based feeding does. It sacrifices the adult-child relationship in exchange for compliance and more bites that can be tracked neatly on a graph. Healthy, joyful eating takes place within safe, trusting relationships between children and their caregivers. But I want all parents to know that your feeding relationship with your child can still be joyful and healthy, even if we're working together to improve your children's nutrition, teach them feeding skills, help them gain weight, or help them develop strategies for trying new foods. And in my experience, parental anxiety and the child's sense of felt safety during mealtimes are often the first things responsive feeding professionals must address to help get eating on track and make mealtimes joyful. If your child is having difficulty eating or if mealtimes are challenging for them or for you, I want you to know that it's not your fault as a parent or a caregiver. While there are things that responsive feeding professionals can teach you to better support your child at meal times, you're not at fault for not knowing or not doing these things. Our society has a deeply disordered relationship with health, weight, and eating. Many adults, both parents and the professionals working with our kids, are struggling with their own problematic and disordered relationship with food. And that problematic relationship can find its way into how we approach feeding our kids. Even the responsive feeding literature is not free of this problem. In fact, quite a bit of the research into responsive feeding in infancy has been done with the intention to determine how we prevent obesity, which in itself is problematic. This reveals our society's intense fear of fatness, which is the term preferred by fat activists who often face discrimination and reduced access to medical care due to bias related to their weight. Truly responsive feeding isn't about achieving a particular weight or number of foods. It's about nourishing the body, whatever size that body is. And as a whole, I feel that the discourse surrounding feeding therapy often seeks to minimize the societal barriers that families are facing in feeding their children. While there's often a lot of talk about the ways in which income impacts access to healthy eating, many feeding providers, even those who are quite responsive, contend that fresh food is actually less expensive and therefore more accessible to low-income families than prepared or fast food. But it's more than about just money. It's about more than just money. Time is a precious resource that many of our families are short on. They're short on time to shop, time to meal plan, time to prepare meals and learn new recipes, time to introduce new foods that we're asking them to introduce to children, time to prepare and properly store fresh whole foods, time to feed themselves, time to do all the things they need to do as a parent, especially when they're parenting a child who may have additional needs to attend to. And as professionals, we have to be aware that so many of our kids, particularly our neurodivergent kids, are the product of neurodivergent parents who might be struggling with some of their own feeding and executive functioning and emotional regulation and sensory concerns. These things are not happening in a vacuum. They're not happening in isolation. So we have to recognize the interconnectedness of all of these things and the complexity of the barriers families are facing. It's not just as simple as fresh chicken and fresh broccoli is, fewer cents per pound if you don't have the resources from a time, emotional, or cognitive standpoint to really devote to that. It's much more complicated than that. And the fact that parents are often so short on resources to feed their children, particularly their children with feeding differences and challenges, is part of why I think ABA approaches to feeding hold so much appeal. There have even been studies done in the ABA literature to determine how economical an ABA approach to feeding is compared to other approaches. So these kids are being reduced to dollars. Researchers concluded that ABA feeding was appealing from an economical standpoint, in part because it required less time and was therefore less expensive than other methods. But here's the thing. Those results often don't last. And those so-called results can come at a steep price that just can't be measured in dollars. Rather than focusing on how quickly we can get kids in and out of therapy, how quickly we can get them to eating those 30 foods we've targeted and that we want them to eat, we have to focus on the quality of the feeding relationship. And this doesn't happen overnight. And for those of us who are neurodivergent, the simple fact of the matter is that many of us are never going to demonstrate what society considers typical eating, even what the medical profession considers typical eating. The specifics of neurodivergent feeding development and therapy is something I'm very passionate about because it does affect me personally and professionally. And it's something that I will be providing more education and resources for soon. And there are certainly ways that providers and parents can accommodate neurodivergence within a responsive feeding framework. And I look forward to contributing to that discourse in the future. So I'd like to end by sharing some information about an advocacy project that the Therapist Neurodiversity Collective is working on. And we're doing this to help raise awareness of feeding trauma and engage in advocacy efforts to increase public education about ethical alternatives. If you or someone you're caring for has experienced traumatic feeding therapy, like the therapies we discussed earlier in this presentation, please feel free to contact us if you'd like to share your experience. You can reach me through the email found here at the bottom of this slide. Through this project, we hope to help people who have been violated by these therapies regain their autonomy and begin to heal. Those who are interested will be able to share their experience in whatever format they feel most comfortable with and can remain anonymous if they choose to. So far, participants have chosen to have me write articles about their experiences and my interviews with them, and others are considering writing their own accounts and potentially creating videos. It's truly up to those who wish to participate. Dehumanizing feeding therapies have caused so much damage to so many people and so many children, and we hope that this project will help ensure that no one else has to experience that trauma. And here is more references than you maybe ever wanted on ABA-based feeding.
Self here. Caroline, I'm just joining you again. Thank you so much. That was fantastic. And some of that was difficult, and difficult to hear and imagine and know that is happening. But I think really important, and I appreciate all the work and research you've done around this. And
that was one of the things that was challenging in creating this presentation. Is I feel sometimes in my profession there's a lot of pressure to talk about kind of the nice things in a nice way, and there isn't a way to talk about these things without really exposing them for what they are. And I hope that anyone who felt uncomfortable is able to recognize that their fleeting experience of discomfort is nothing compared to what these kids are experiencing. I mean, I've held these children while they've sobbed, coming straight from their day-long 8-hour feeding clinic at an ABA clinic. And, our 30-minute speech session is just us regulating and them crying. And sorry, it's emotional. It's very, it's difficult.
Yeah, absolutely. Absolutely. Difficult, but important. And I think, the more that we can do to, raise awareness about so many things that are happening often in the name of, treatment that are really causing a lot of harm, I think is so important. And really want to thank you for sharing all this with us. We do have a couple questions that are popping up here. And let me bring this one up here from Jennifer. Jennifer says, how do you find an SLP or OT who uses responsive feeding therapy? Also, how do sensory issues factor into responsive feeding therapy?
Okay, I'll respond to the first one first. So what I would highly recommend is I would recommend that any parent consult that responsive feeding white paper that I mentioned. If you go to the Therapist Neurodiversity Collective, I don't know if I haven't submitted that article yet. I'll make sure that we can make sure people have access to that document. But
yeah, I did put a link to the white paper in the chat, so hopefully people will be able to find that.
I recommend you look through that and become familiar with that. And unfortunately, it does come to a point where you do have to interview the provider. And any provider who is not willing to talk to you and have at least a 15-minute conversation with you about their therapy approaches is probably not one that you're going to want to be working with. So I highly recommend that parents check that out and look at that information and ask the therapist, what is your approach to feeding? What kind of feeding approaches have you been trained in? Because there's certainly some that are more behavioral than others. And I'm working on some more articles for the collective that'll detail this more specifically, because this is a question I get a lot. But really, you're going to want to try to find a therapist that's not using rewards, that is really cognizant of the child's need for bodily autonomy and making sure that they're consenting to therapy, and who's recognizing that this is really hard for our kids. And this is not just a matter of you eat your broccoli and then you get your dessert. It's much more complicated than that. So that's what I would recommend as far as finding a therapist. What was the second part of the question? I think it was sensory related.
Also, how does, and I'll bring it back up here. Also, how does sensory issues factor into responsive feeding therapy?
Yeah. So any therapist that's truly responsive in their feeding is going to recognize the signs that a child is demonstrating that they're having difficulty with a sensory component of food. So children, there's a lot of physiological things that we often do inadvertently, things like gag, facial grimace, finger splays, things like that that demonstrate that a child is having an adverse sensory response. Some children are also hypo or undersensitive. Those are my kids that'll take a bulb of garlic and just gnaw on it, which is impressive to see because they're really craving that input. So the sensory aspects are we don't have enough time to get into all of it, but when it comes to responsive feeding therapy, you want a therapist who's not only recognizing how to see the signs of a positive or negative reaction to sensory input, but I'm also hopeful that more and more therapists are going to recognize the ways in which our kids' neurology and sensory systems are just different. And as a result, they're processing sensory information differently. We're not going to be able to systematically desensitize them. There's some things that they're just not going to be able to tolerate. So the goal should never be tolerance. It should be self-advocacy.
I can't even begin to imagine how much harm this causes, how much harm these approaches where you're using restraint and you're taking away autonomy. I can't imagine the long-term effects. I mean, it seems to me that the long-term impact is at odds with the goal of even if you were to accept that the goal of the feeding program was to offer some help, it would seem that it would be the opposite in kind of in the long term. Has that been your experience?
Yes, I have had parents report, sorry, I get emotional about this, that their children have become suicidal. After that. The egregious violation of their bodily autonomy was so devastating that it exacerbated existing mental health needs, because these children who, unfortunately, so many kids, they're going through years and years of feeding therapy, and they finally end up at a place like, some of these very intensive hospital-based programs that are informed by ABA. And it's just, we're talking 8 hours. They might be sitting in that chair 3 times a day for as long as it takes to really essentially break them. Some providers call it breaking the child. And it is absolutely devastating. We don't have any long-term adverse event reporting on what are the actual negative impacts of these therapies. But if we look at the eating disorder literature at anorexic individuals who have been force-fed, typically they're not force-fed manually. It's more through a nasogastric tube is forcibly enforced, which is traumatic in its own way. But what they find is that the psychological impact of anorexia doesn't go away. In fact, some of those things are exacerbated, and that forceful feeding completely erodes the trusting relationship between provider and patient.
Right.
So at the end of the day, yes, you got calories in, but you did nothing to address the core problem.
Right. Yeah, and Eamon mentioned here, and I think this is in line with what you were saying. There's post-traumatic stress disorder, CPTSD. There's a lot of potential for long-term impact, and we get interesting questions often about the connection between physical restraint or seclusion and trauma. And, the way I look at things like this is, people are often looking for the study. Where's the study that shows that this is traumatic? And the question in my mind is always, how can you not imagine that it's traumatic, being held down to the ground and refuse to leave, or, any kind of, act that's taken away your autonomy. These are things that are extremely, extremely traumatic.
And what's fascinating is the elitism in the academy when there are researchers or professionals who, God forbid, don't have a PhD, who, speak out about these things. You think of Henny Kupferstein, or Kat Kupferstein. I feel bad, I might not be pronouncing her name right, but she wrote that really influential study on PTSD in as a result of ABA therapy. And she was completely eviscerated by people like Justin Leaf and other huge supporters of ABA in such a disrespectful way. And you see the way that we're engaging academically with autistic and highly qualified individuals engaging in research.
Right.
And it's, those who, I don't do well with idioms and figurative language, but this is an example of, we shouldn't throw stones when we're living in glass houses, as I hope it was conveyed in my presentation. ABA research is fundamentally flawed.
Mm-hmm.
So to call this the gold standard, to tout this evidence as a reason for doing this is really a misrepresentation of what the data is saying.
Right. Well, listen, I really appreciate you coming by for this conversation today, and I'd like to ask that you, as you're doing more, as you're writing pieces, that you share those with us so we can share them with our audience. Would love to have you back again to talk more about this. This has been really informative, for me, and I'm sure many other people that are out there and people that are experiencing these issues. And I can't help but think about the cascading impact that these things have, when you're going through a process like this related to feeding, and how that just continues to affect the relationship, the child, the trust, the sense of autonomy. There's so much damage that can be done here. Really appreciate all the research that you're doing, and want to thank you for coming out today. I'll be in touch with you hopefully soon, and as you're sharing more, please share it with us, and we'll make sure to get it out there. So thank you, Caroline. If there's any last words you have, I'd love to give you an opportunity.
Oh, I think it's just, my hope is that, I really hope within my lifetime that we stop subjecting kids to these kinds of therapies. I don't think we should even be calling them therapies, but I just really want parents to know, if something that any therapist, educator, any professional is doing makes you feel uncomfortable and they try to dismiss it, I really hope you go with your gut, because you're the most powerful advocate for your child, and you want to demonstrate that advocacy in front of your child. So I really hope that, you can use this information to more powerfully advocate for those that you care about.
Absolutely. Thank you so much. I'm going to let you go, and I'm just going to give an announcement here to the rest, but thank you so much, and we'll talk to you again soon.
All right. Thank you.
Thanks. So just a quick announcement. I hope you enjoyed the program today. Really, really an interesting topic. And, one, again, I feel like I'm always learning a lot from the amazing guests that we have on here. So thank you for joining us. I do want to mention to you that we've got another show coming up in 2 weeks, as always. This one's going to go in a slightly different direction as well. We're going to be talking to an artist that was influenced by seclusion, that is actually opening up an art exhibit about the use of seclusion. It's called Breaking the Rules, A Minor Spatial Inconvenience. So Lily Frame is going to be joining us and hopefully giving us a tour of the artwork that she's putting in an installation. So be sure to join us, and we'll have plenty more coming at you. So thank you all so much. Appreciate you joining us today, and we'll look forward to seeing you again soon.